Started. Good afternoon, everyone, and welcome to CDC's Hemoglobinopathy webinar series. I'm Mary Houlihan from the Division of Blood Disorders, and I'm going to be serving as today's moderator. So before we start today's presentation, I just want to go over a few points like we do every time. So as a reminder, as the conference leader, I'm going to mute all of the conference lines to eliminate background noise. After the presentation, we will allow questions, and at that time, you're going to have to press *6 to individually unmute your line when you want to speak. Since we're on the phone and we can't actually see who wishes to make a comment, what I would ask is that you please electronically raise your hand if you would like to speak. You can look at your screen right now to see how to do that. In order to raise your hand, you want to click on the Q&A tab on the menu bar of your webinar screen. And then once you're in the Q&A window, click on the hand icon in the upper right corner. And this will display your name to the meeting presenters. And once I see your name up there, I will call on the participants as the names are displayed. Once your name is called, again, remember, you're going to press *6 to unmute. And then I'd ask that you state your name and affiliation before asking a question or providing a comment. So everyone can, if you'd like, you can raise your hand during the presentation, but we're going to wait until the discussion period after the presentation to address those comments. I also wanted to let you know that the session is being recorded. So with that being said,
Hello? Hello? Hello?
Hello?
Yes.
Hi, this is Mary Bentley Lamar, just calling in for the webinar.
Hi, it seems like we're having some technical difficulties with the audio.
Hello?
Okay. So give us just a moment.
Sure. Okay.
hey, have you been able to hear me speaking?
No, we just heard you now.
Oh, I think it needed to.
Okay. So I'm going to just start with the introduction of Dr. DeBaun and our topic today on the medical home model for sickle cell disease. So our presenter, Dr. Michael DeBaun, is an internationally recognized physician scientist whose research resulted in fundamental advances in hematology and oncology. He has elucidated the clinical significance of silent cerebral infarction in children with sickle cell anemia, setting the groundwork for an international multi-centered clinical trial. Dr. DeBaun is also the principal investigator of the sleep and asthma cohort study. Dr. DeBaun received his medical doctorate and a master's degree in health services research from Stanford University Medical School. He completed pediatric residency at St. Louis Children's Hospital and Washington University School of Medicine, and received a master's in public health from the Johns Hopkins School of Public Health. In 2004, Dr. DeBaun was the primary physician author for the Sickle Cell Disease Treatment Act, which is now a federal law in the United States focused on creating community-based sickle cell disease centers and improving access to sickle cell trait testing. Prior to his faculty appointment at Vanderbilt, he was the inaugural recipient of the Faring Family Chair in Pediatrics and Professor of Neurology and Biostatistics at Washington University School of Medicine. So at this time, Dr. DeBaun, if you'd like to unmute your phone and you can begin addressing the audience.
Thank you. Can you hear me?
It's very, very faint.
I'm talking on a landline, and I'm talking on a landline. It should be.
Okay. You sound good now. Thank you.
Okay. So the title of this talk is The Medical Home for Sickle Cell Disease, a New Paradigm for Healthcare Delivery. Do I just tell you next slide? Because obviously I can't prompt you to this. So what's the perspective from the patient? I think this is a very important concept here. This was given by the chaplain that worked with me while I was in St. Louis, Michael Johnson. And he constantly reminded us that when he was diagnosed with sickle cell disease, the healthcare team told his mother that he was not going to live until his 18th birthday. Next slide. here is a Kaplan-Meier plot identifying on the x-axis years of follow-up since birth and the fraction surviving. And what I've done here is identify the major studies and shown you that in 1973 and 75, you can see that approximately 25% of the individuals with sickle cell disease were expected to die before their 18th birthday. And clearly with each time period, in the red 1983 to 1990, there's a dramatic increase in the overall survival. And now in the current era, the most recent data was published by Quinn et al. In Blood. You can anticipate that individuals, children, infants born with sickle disease should live throughout their childhood and young adulthood. And that is our expectation as pediatricians, is that we will be able to hand off our patients to our adult counterparts to provide care. Next slide. So when children with sickle cell disease are
on the phone, yeah.
Hello?
I'm going to interrupt you. I think the mute didn't work before, so I'm going to mute all the lines again, and then Dr. DeBaun, if you can press *6 and start speaking, that would be great.
You want me to press *6?
Conference is now in silent mode.
*6. We still can't hear you. I'm sorry. Yes, perfect.
Okay.
Great.
All right. You can hear me now? Is this fine?
Yes, perfect. Thank you.
So this slide is intended to give you a snapshot of what sickle cell disease looks like for a 10-year-old. And this is data obtained from the silent infarct transfusion trial for children who were in the United States at various medical centers. So the entry criteria for this trial to be screened were, in fact, that they could not have been on hydroxyurea. So among approximately children of the age of 10, you would expect them to have about 2 hospitalizations over a 3-year period for pain. In terms of individual educational plans, about 15% of the children will have an IEP when compared to the U.S. population. Medicaid health coverage, these are children who participated in being screened for the silent infarct transfusion trial. 70% of those children had Medicaid versus 15% of the U.S. population has Medicaid. The yearly household income per capita was $8,500 for children who participated in the SID trial living in the United States versus $27,000. And the average household income for children participating in the trial was $38,000 versus $50,000. So clearly, what you see here is that the demographics of children with sickle cell disease is really quite different when compared to the general population. And my experience, and I dare say the experience of others, is that the demographics of children with sickle cell disease is unlike any other chronic disease that we provide medical care for in the United States, at least in the pediatric population, and probably would be the same in the adult. They're disproportionately poor. They disproportionately have Medicaid health coverage, and they disproportionately are African American, more than 90%. Next slide, please.
Hello?
Hello?
Hello, this is Dr. McMahon. Dr. DeBaun's voice keeps on fading off. Is it just my line?
Yes, I believe it's just your line. We can hear him fine.
Oh, okay. Is there anything I can do?
No, I think that's probably something on your end that'll need to be taken care of.
Okay, thanks.
Hello? Should I begin now?
Yes, please. I'm sorry about the interruption.
Okay, no problem. So what do we expect of this 10-year-old in the family? This is what the burden that we have placed on the family. We expect, in keeping with the American Academy of Pediatrics and the medical home model, we expect that each child have an annual visit for a pediatrician. We also expect that each child see a hematologist at least once. General recommendations for ophthalmology visits because of complications related to the eye, particularly retinopathy. we expect every child to see an ophthalmologist at least once. Dental hygiene is important for all children, but particularly for children with sickle cell disease, so we expect them to see a dentist at least once. For children with hemoglobin SS, the standard approach for prevention of primary stroke is a transcranial Doppler measurement, and so we expect them to have that done at least once. The annual influenza shot is expected to be given if the annual visit to the hematologist is in the spring or the summer or some other time other than the flu season, then we expect them to come back for a flu shot. And if the patient is placed on hydroxyurea, there are multiple different standards around the country in terms of how often such patients should be seen. At our own site, we expect the patients to be seen every 2 months when they're on a stable dose. Other sites have liberalized that interval to 3 to 4 months. But you can see that we expect working family to see a physician at least 9 times a year. Clearly, this is a burden for any working family, as well as for the students who are trying to go to school and are usually missing an appointment or missing the school to go to visit a physician. Next slide. So what happens when this 10-year-old develops comorbidity, a comorbid condition? Asthma is prominent in the African-American community, and particularly it's prominent, equally as prominent in children with sickle cell disease. Approximately 1 in 5 children with sickle cell disease will have asthma. When you talk to a pulmonologist and you describe to them the morbidity associated with asthma in this patient population, majority of them would expect that they have a spirometry evaluation at least once and a follow-up with their asthma specialist at least once a year. In addition, for those who have an elevated TCD measurement, approximately 10% of the patient population, there's an expectation that they have monthly blood transfusion therapy for an indefinite period of time. Commonly, this is a 2-visit for most families where they come in for the type and cross, check their hemoglobin and the hemoglobin S to see if they're actually optimal timing for their transfusion, and then they come back the next day for the transfusion. And typically, this requires an indefinite treatment with inoculation, most often now oral, but also can be subcutaneous. And this, with the advent of the use of transcranial Doppler assessments for primary prevention of strokes coupled with blood transfusion, the rate of avert strokes has dropped significantly. But most large sickle cell centers still have a considerable number of children who've had strokes, and they require monthly blood transfusion therapy, as well as biannual visits to neurologists for cognitive testing. So this is an article that was recently published in the New England Journal of Medicine. I think it very nicely gives a snapshot of the challenges of being poor with a chronic disease and seeking subspecialty service. Somebody's typing in the background. I think everybody can hear that. I know at least I can. So what they did was specifically they looked at public insurance versus Blue Cross Blue Shield and to assess the access to specialty care for these children. Each of 273 clinics were called twice for a total of 546 calls by the same caller. The calls were made 1 month apart, and the order of the reported insurance status was randomly assigned. And as is the case in many locations, asthma clinics included not only pulmonary but allergy immunology clinics. The results were really quite astounding to the general public, but probably not for the pediatricians who take care of children who are on Medicaid or CHIP. At least 66% of callers on Medicaid or CHIP were denied an appointment. Compare that to private insurance, it was 11%, and the average wait time to see a specialist for those who would accept Medicaid and CHIP was 22 days longer. What you see here is a graph showing the specialty care appointments for children according to the types of insurance. On the x-axis is the different types of specialty care. and on the y-axis is the clinical scheduling, especially physician appointments for children. And I just want to point out the dramatic difference. We all know asthma is an epidemic, particularly for urban, poor black children. And you can see here in the fourth category that 100% of the children who had asthma had access to subspecialty care versus 45% of the children on public insurance. So what does this disease look like? As we now know, we expect children with sickle cell disease to become young adults. And this was an email that was sent to me by a patient that I've been taking care of for over 15 years. I know that this has been long overdue since we've last talked, but I'm hoping to break the silence today. I wanted to ask you if you knew of any adult hematologist that you personally approved of who provides good care. Since I've been here, despite doing everything that I've been told to do, taking hydroxyurea and folic acid the right way, and even taking OxyContin and oxycodone around the clock, nonstop, I've still been in constant pain. My hemoglobin will not stay up past 3.7, sometimes lower, for more than a week at a time, despite receiving constant blood transfusions and a series of shots every 3 weeks. I feel as though the longer I stay here, the worse my health becomes. So we have this challenge in the health community, this imbalance between the number of adult providers and the number of adults with sickle cell disease. And I think it's fair to say that this problem has been in existence for at least the last 15 years. There's a dramatic challenge for the adult with sickle cell disease to provide a provider, to find a provider who's willing to take the time that it requires to become their primary care provider. Ultimately, there's simply not enough hematologists, adult hematologists, who are willing or able to take care of the adult patients with sickle cell disease, and this is going to require the system. Hello, somebody's still typing. I can
Excuse me, if you have the phone off of mute, please put it on mute, please.
Yes.
Everyone. Thank you.
Yes. Okay, back to the point, which is that clearly in the next decade, the number of adult hematologists who provide care for individuals with sickle cell disease is not going to increase dramatically. Instead, I think in terms of the crisis that we've reached here, we'll have to turn to our primary care colleagues as well as individuals who are physician extenders, nurse practitioners, and physician assistants who are willing to be educated about how to care for this population and at least be the first pass for management of their disease. Next slide. What type of comorbidities are we expected to see in adults with sickle cell disease? Pulmonary hypertension or elevated TRJ velocity, which has been associated with premature death, occurs in about 30%. Silent cerebral infarcts, which is clearly affects their cognition, executive function, occurs in about 35%. I just want to pause here about the silent cerebral infarcts. This data was taken from France cohort, which had about 35% of the patients having a silent cerebral infarct by their 14th birthday. These are individuals with hemoglobin SS. What this translates to is when you have an adult with silent cerebral infarcts, they may not follow directions well, not because they have intentions not to follow the instructions about taking the medication, but because they don't have the capacity to do this because of injury to the brain. And in talking to my adult colleagues, this is often forgotten when they describe a patient as being non-adherent or is not able to follow directions well. The vascular necrosis of the hips and the shoulders occur in about a fifth of our patients. Asthma does occur in the adult patient population, coupled with persistent or intermittent wheezing. And, of course, there's chronic sickle cell lung disease, which is a major cause of mortality in this patient population. The natural history and etiology of chronic lung disease is not well known, and we're still kind of grasping at straws in terms of not only the epidemiology of chronic lung disease, but also the etiology of chronic lung disease. Birth strokes do occur in the adult population. Most likely there are going to be cerebral hemorrhages. and renal failure also occurs. So we here at Vanderbilt decided to try a new model, a model for comprehensive care using a medical home strategy. Next slide. So the mission of this activity is to provide in a medical home setting the best available medical care and educational support and research for all children and adults and their families whose lives are affected by sickle cell disease. Our objectives include increasing the proportion of children and adults with sickle cell disease that have a medical home, to provide preconception hemoglobinopathy trait testing and education in their medical home. Let me just point out that in the Federal Qualified Health Center that we are working with, in the previous year, despite having well over 10,000 African Americans, go back one, there was no individual who actually received genetic counseling for their sickle cell trait. So, and I do not think that their lack of preconception hemoglobinopathy trait testing and education is, or the lack thereof, is unique to this community health center. I would dare say that many community health centers do not provide preconception hemoglobinopathy trait testing and education. Then our third objective is to increase knowledge base about sickle cell disease management among the community and local healthcare. So many definitions of the medical home. We have chosen this as our gold standard. And the medical home definition includes the following, but is not limited to: a usual source of care, having a personal doctor or a nurse, receiving all needed referrals for specialty care, receiving help as needed in coordinating health-related care, and receiving family-centered care. Middle Tennessee region, which is where we are located, we estimate there are 820 children and adults with sickle cell disease who live here. Look at the pathologists in the region who are providing medical care for this patient population. On the books, not necessarily patients who've been seen, but at least on the books, we have about 500. This is the older version. What I want to point out to you is that the Matthew Walker Community Health Center is a network that is located in Nashville, and if you look in the top left-hand corner of the box, they have a satellite site there in Clarksville, which is actually not very far from Fort Campbell, which has a large number of African Americans with sickle cell disease in that region, and then they have a clinic in Murfreesboro. So we set out to look at what was the assessment of medical home in our own patient populations. We've done this as a matter of QA, and again, we use the approach that Dr. Strickland used from the HRSA manuscript that was previously published, and this is from the National Survey of Children with Special Healthcare Needs 2005 and 2006. And go back one, and what we defined as not having a medical home is the following. Number one is the patient could not, or the family could not identify a primary care physician by name. So it wasn't sufficient if someone said, if we asked the family who their primary care provider was, and they said Matthew Walker Clinic. In our opinion, that's not reflective of a medical home. And also, if they stated they had never been treated by one or more primary care physician or nurses when identifying a provider, and have not seen the identified provider in more than 2 years. So when we looked at children with sickle cell disease who were seen this past November, 38% of the children had no basis for a medical home. And in fact, having interviewed many of these families myself, their strategy or discussion points were, we don't need a primary care doc, you're our doc, why aren't you our primary care doc? we are slowly trying to re-educate our families about the fact that we are not their primary care physicians, and routine care that a pediatrician or a gynecologist should be providing for this patient population is not best served in a hematology office. When we look at the adults with sickle cell disease in the Meharry and Vanderbilt clinic during the same window of time, approximately half of the adults did not have a primary. So when we try to address this issue of family-centered care, the challenge in the adult literature, because we could not find definitions that referred to an adult population. So we essentially used the same technique that Bonnie Strickland had offered us for the children with special health care needs, and used her same definition of family-centered care. And that was if the respondent answered usually or always for each item, then the child was considered to have received family-centered care. And that's on the following 6 questions. There is a 7th question which relates to adequacy of translation. However, translator services. However, in our patient population, we only have one patient. So when you look at the survey for children, you can see that majority of the children fall into the always or usual in terms of has your child been treated by one or more doctors or nurses. Next slide. And this is a slide that represents the adult population, and it states, have you been treated by one or more doctors or nurses? And this is referring to their primary care. And you can see that the majority of the adult patients have never been treated by. So when you look specifically at family-centered care for children and adults, not surprising in many ways based on the multidisciplinary approach that pediatricians have and perhaps a holistic approach that pediatricians have, that only 16% of the children did not receive family-centered care, but then when you looked at the adults, 60%, the majority of the adults had not received family. So what's the relationship between the healthcare system and the community? We, at our site, have elected to use the chronic care model, which is a fairly standard model, actually introduced originally by internists, at least. It's a Venn diagram with overlapping areas. The first area, obviously, is a child or adult with sickle cell disease. Then you have the sickle cell disease specialists and other specialists, which obviously for this patient population should include pulmonologists as well as the neurologists. Hold on one second. As well as neurologists, ophthalmologists, dental care. There should clearly be primary care providers who are serve as the basis for the medical home. Of course, in the chronic care model, there should be case managers. So the spectrum of continuous health care, we are embarking on this experiment, quite frankly, as a single unit, where we will see the patients in a single facility in concert with the primary care providers from birth throughout. In this facility and on the team at this Federal Qualified Health Center, Matthew Walker is a pediatrician, an internist. We have a pediatric and 2 adult hematologists. We have a family practice assistant, a psychologist, a pulmonologist, an asthma specialist. Go back one slide. Currently being educated about how to take care of patients with sickle cell disease and simultaneously recognizing that we'll also have a respiratory therapist who will conduct pulmonary function tests on site, a genetic counselor, and a medical social worker. let me just take one step back and say that of the list of the people who I have identified here, there are only 2 hires that are new to the program. What existed prior were expertise in 3 different locations, and we've essentially cobbled together the team from already predominantly pre-existing resources. Next slide. So the healthcare team, we decided to divide this up into units. Infant and young children will be 0 to 5. The predominant care will be actually delivered by the general pediatrician. From 5 to 15, the predominant care will be delivered by the pediatrician and the hematologist. From the transition care and the nurse practitioner, and the transition care will be from 15 to 25. Then over 25 will be the internist with the 2 adult hematologists and the nurse practitioner or physician assistant from the then there will be, for asthma care, there's a respiratory therapist, a nurse practitioner, and then the pediatric and adult hematologist and a pediatric, and we are actually need to fill in the gap for the adult pulmonologist. And we will eventually, because of the predominance of hydroxyurea, create a team that's totally focused on hydroxyurea. So the services that will be provided include a comprehensive health center at Matthew Walker, transportation to those in need. These are already pre-existing services that are provided at the FQHC, translational services. And, of course, because of the unique environment of being a federal qualified health center, there's actually no financial or minimum financial obligation. Now, I would like to pause here. I did have a vignette that I inserted earlier today, but did get and last week I saw a family of 3 children, 2 of which had sickle cell disease. Mom and dad accompanied the 2 children. And we were describing our transition from the tertiary care model where the home model where we will actually physically move to deliver. The process of driving this transition, the mother mentioned that her husband had sickle cell disease, and I brought up a conversation about, well, where does he get his care? And the husband said, in fact, that he hadn't seen a physician in over a decade. I asked him, and he was employed as working as a cook, but without insurance, and so health insurance. And so when I asked him if he would be willing to see a physician, the wife was the one who spoke up and said absolutely. And it turns out, as part of our training, the physician assistant that's working with us was able to see him the following week. And not only was he seen at Matthew Walker that week, but he had retinal detachment that hadn't been evaluated by an ophthalmologist in over an appointment for an ophthalmologist, and he hadn't seen a dentist in over 18 years. So he was able to have an appointment to see a dentist. So this is what we think is happening over and over again for many of our adults with sickle cell disease without access to health care, without a primary care provider to more or less triage these non-hematologic issues. They go without any attention. Next slide. So what are the challenges with this model? This is a different model from what any of our patients have been exposed to. Many of them are anxious about leaving a tertiary care medical center where the perception of care is supposedly better than it is in a community health center. And we've received that feedback from many of our families, particularly located in a neighborhood that primarily serves the underserved. I'm concerned that quality of care will be less. And we go back. I was walking through this. So insurance restrictions have proven to be a challenge, although not for FQHC, more so for some of the providers, and their previous payer mix was such that the majority of the patients had Blue Cross, Blue Shield, or some other third-party payer other than public health insurance. And there's, again, a perception that moving to a community health center will be less standard care, despite the fact that the team and the providers are the same in terms of the specialists, and we're actually providing more services than have been previously provided in the past. We are challenged with this concept of how do you introduce genetic counseling in a community health center where the average visit is less than 10 minutes. We are challenged with defining the patient population, and then we have a graphic, and then what is our catchment area for this regional medical center. This is a little window of time of looking into how we as a team have addressed our strengths and weaknesses. This is kind of being inside of our room and our team meetings. We clearly thought that we had strengths, we have weaknesses, there are unique opportunities, and then I want to focus on the last box, which is the threats for this model, which includes our concerns that the patients have of losing control of the physician and choice. And obviously, this is a paradigm shift which requires a change, and there's hesitancy in the patients, particularly say the system has worked for us. Why should we want to change the system, and what's our motivation for changing the system? And the majority of the patients, this has been driven by the Vanderbilt leadership, and the majority of the patients have their medical care at Vanderbilt, and their point of view was, why do we want to move somewhere else? So we are working on trying to address some of these threats, but it is a part of the process that we're moving forward on. Next slide. When we surveyed our families, we wanted to take a look at what they wanted us to address as a team. We had a zoo day with over 350 individuals that attended, and each family was asked to fill out a survey regarding what are their concerns and how should we address their concerns as their team. And as you can see on the left-hand side, I'll just go with the top three. Pain management was critical, school intervention for many of our students, and then coping with sickle cell disease. These were the priorities that the families provided to us that we should focus on as their. Next slide. So that summarizes the concept of the medical home for sickle cell disease. I would say that this is a concept in evolution. I welcome any comments and criticisms about how we can do this better. Thank you very much.
Thank you so much, Dr. DeBaun. We really appreciate it. It was a great presentation. So we're now going to open the lines for questions. I want to remind everybody to please remember to unmute your phone individually by pressing *6, but only when you're asking a question. After you finish asking your question, you're going to need to press *6 again so that we don't all hear your background noise. So as a reminder, if you have a question, you need to raise your hand electronically, and that way we'll be able to see your names in the order that they were received. So we have this line scheduled for about 20 more minutes. And at that point, if we're still asking questions, I am going to need to put an end to the line of questions for the end of the hour presentation. So I'm going to start off with, if anyone has a question, I'd say there were some comments about the noise level, but does anyone have a question for Dr. DeBaun at this time? If you do, you can press *6 and ask your question.
Some questions.
Anybody have a question at this time? If you're trying to ask it, we can't hear you, so you'll need to press *6, please.
Hi, Dr. DeBaun. This is Althea. I have a question. Why did you choose to have a specific focus on hydroxyurea? Or had you considered having, a focus on other disease-modifying therapies as well, like a transfusion focus or any of those?
Yes. The answer to the question deals directly with the evidence to support that there's for the majority of patients with sickle cell disease, particularly individuals with hemoglobin SS, the use of hydroxyurea is life-altering. and we feel so strongly about this that initially our team had made a decision after reviewing the literature that every teenager by the age of 16 should be started on hydroxyurea. This is based on two studies, observational studies, one in Greece and one in the United States, where individuals who were placed on hydroxyurea because supposedly they had the more severe phenotype, they had multiple pain episodes, acute chest syndrome, or the like, were then compared to individuals who had, quote-unquote, the milder phenotype, individuals who had less complications initially. And much to everyone's surprise, or perhaps not, in both cohorts, which were over 17 years in follow-up, the individuals who had the more severe disease were the ones who outlived the individuals who had less severe. And so we felt that that was an important aspect of the care of patients with sickle cell disease.
To that same end, do you see any barriers to that, or how are patients receiving the idea of kind of universal implementation of hydroxyurea?
Right. So I'm going to. So that's what we did about 12 months ago. But then I started to see the patients since I'm new to Vanderbilt, and it turns out that unbeknownst to myself, there were most of the children over 5 years of age were on hydroxyurea. And so the de facto standard here was to put a child on hydroxyurea almost uniformly over the age of 5 with SS. And so in talking to those families, their experience with this drug was quite different than my previous experience in St. Louis, where we had reserved the treatment for those who fell into the severe category. And as a result of the experience that we have had over the last 9 months, uniformly we agreed that we would lower the age of starting hydroxyurea, regardless of symptoms, by the age of 5. And our experience has been for those few patients who are not already on hydroxyurea, because they have accepted this therapy moderately well. I would say 9 out of 10 families have agreed that being on hydroxyurea is a reasonable strategy. We've created a parent handbook that is specific for a reading level that we so that the lay public, so the public can understand it. We give them the handbook before we start therapy, and we explain the pros and cons. And I would say the majority of the individuals are receptive of starting on hydroxyurea, but our numbers are small because just about everyone with SS over the age of 5 are on the drug. In our adult population, it's a little bit more challenging because they've gotten to a point in their life where they haven't been on the drug. And so for our adult providers, there's been more resistance because the question is, well, why are you just now starting us on this drug? But we're moving forward in a systematic fashion to re-educate our families about the importance of being on.
Great. Thank you, Dr. DeBaun.
So it looks like we have a question now from Irene. Irene, if you'd like to ask Dr. DeBaun your question, just remember to please press *6 so we can hear you. Are you still on the phone, Irene? You had a question. I can read it out loud. How long has the medical home model been in place, and how is it going? That's the question we have from Irene.
Right. Well, we are still in transition, and so we're educating the pediatrician and the physician assistant. They're coming to clinic on the adult side. The physician assistant shadows me for pediatric patients 1 day a week, and shadows the adult provider the other day a week. And then the pediatrician has shadowed me 1 day a week as well. And this is to hopefully re-educate them about how to manage sickle cell disease and what the cadence of our visits are, what we believe are important to emphasize. And it does not fit into their standard 10-minute visit, which is one of the biggest challenges. So they have to go back and do their templates for patients with sickle cell disease, because the templates for patients without sickle cell disease does not reflect what we would commonly do.
Wonderful. Thank you so much. We now have a question from Mark S. Mark, if you're on the phone and you'd like to press *6 to ask your question.
Mark Swanson, can you hear me?
Yes, we can.
Yeah, I'm a developmental pediatrician, and have written an article in the American Journal of Preventive Medicine about the disabling process of sickle cell disease, just got published a few months ago. And I followed kids with sickle cell from a developmental standpoint for many years. So I'm wondering in your model, if since the school problems is a number 2 issue for the families, if you've thought about incorporating some more personnel or effort into helping the families have their kids cope with school difficulties. And my experience has been in rural areas like in Arkansas that the schools sometimes not very well do not know much about sickle cell disease, and they don't make many accommodations. Some kids do have IEPs, but some kids who don't have IEPs still need some accommodations in terms of missed school and being on pain medication. There are a whole host of factors which make school success a challenge for kids with sickle cell disease. So that dimension might be something to think about in a model. No, you can't do everything in a model, but that connection to school performance, which is, of course, the most important part of a kid's life, I think is an important dimension to add to any kind of medical home or kind of comprehensive care setting for kids with sickle cell.
I couldn't agree with you more. We have a school inventory for every child that we see, every student that we see. We have a psychologist that works with us she's full-time. She only works with children and adults with sickle cell disease. And any child that we identify who is missing school or who has academic problems, we perform a cognitive testing on. And then also follow that up after the cognitive testing has been done with support via the IEP, recognizing the importance of that.
I think what we found in some rural areas I worked in, we actually had to go, I don't know if you go to the IEP meetings, but sometimes the school is a little bit skeptical of some of the things that come up. So I think families may not be quite as comfortable with advocating for their child because the schools can be a little bit intimidating, but that I think ends up being kind of a sticky point for families because they feel a little powerless and frustrated with getting things from the school.
I agree with you.
Wonderful, thank you. Now we have another question from, it looks like maybe from Mary Bentley Lamar, and her question is, what direction do you suggest community-based organizations play in fostering medical homes and encouraging more physicians to provide adult care for sickle cell disease?
Well, that's a challenge, particularly without resources. I think the community-based organizations can leverage their political might towards their legislators, the individuals who are voted into office, and explain to them the lack of access to health care for adults with sickle cell disease. Adults with chronic disease in general, but particularly adults with sickle cell disease. I think without that type of political pressure, there's going to be very limited leverage that one can exercise. It's fiscally not a viable solution to take care of patients who are disproportionately poor. Very little profit in it. And unfortunately, in our current system of health care, the reimbursement is the driver for patient services. With the Affordable Care Act that will be forthcoming for most Americans in the United States in the not-too-distant future, this will provide insurance status for many of the adults who do not have insurance. However, it doesn't mean that physicians will provide services just simply because they have federal-sponsored health insurance. And again, this is going to require some support via the legislators to facilitate care in community health centers, which I think is ultimately going to be the stopping ground for many of the 30 million that will receive care as a result of the American Health Care Plan or Affordability Act.
Great, thank you. So I don't see any more questions that have been asked on the computer. Does anybody have anything they'd like to ask Dr. DeBaun in our few remaining minutes via the phone? If you do, you can press *6 and introduce yourself. Okay, so it looks like that's it for today. Thank you so much, Dr. DeBaun. This was wonderful.
All right, thank you.
Yes.
Nice
So I wanted to remind everyone that our next webinar is going to take place on Thursday, March 22nd. The title of that will be Strategies from the Field, Community Partnership in Health Education. It's going to be presented by a panel of state agencies and partners in hemoglobinopathies. If you have any questions about that webinar or anything about this series in general, please feel free to contact Shay Pope, spope@cdc.gov. And as a reminder, the recorded webinars are being archived and made available at scinfo.org under the webinars toolbar. So thank you again, Dr. DeBaun, and thank you everyone who listened in and watched the webinar today. We had a huge amount of people listening today. So thank you very much. Bye-bye.